Good afternoon, ladies and gentlemen. We're very proud of the fact we get only the best for these seminars. Last week we had Sir John Bell, Regis Chair of Physics at the University of Oxford, clearly at the top of his tree. And now we have the equivalent, Sir David Spiegelhalter, who is the equivalent position in his field in statistics. David is the chair of the Winton Centre for Risk and Evidence Communication at Cambridge University, past president of the Royal Statistical Society, fellow of the Royal Society, author of The Art of Statistics, of which we have lots of copies to show you, and a moderately successful contestant in 2011's Winter Wipeout. Now, we like to be up to date at the RSM and to do our research, so I was reading last week about your holiday in Portugal, in which, David, following Mr. Google, you nearly drove up a flight of steps in front of the cathedral at Coimbra, which precipitated a musing on, should we trust algorithms? Now, I know it's not COVID, but you are an expert on this, and we can't resist to ask you, tell us about mutant algorithms, which seem to be all in the news at the moment. David.
Yes, yeah. I've got to be a bit careful what I say because I do have a conflict of interest here. I'm a non-executive director of the UK Stats Authority, and the Office for Statistics Regulation is conducting an inquiry into the use of this algorithm for setting A-level and GCSE results. So I have to be a little bit careful. But speaking more in generalities, I do think it's absolutely crucial that algorithms are subject to proper governance and proper scrutiny, whether they're being used in policing, whether they're being used in medicine, whether they're being used in education, which is a novel application. And that this needs, of course, statistical insight, a lot of statistical inputs, but it's more than just a statistical issue. We have to consider very carefully the impact of the algorithm, the fairness of it, the perceived quality, and so on. And so I do think that this is a wake-up call and an opportunity to develop real strong guidance on how such algorithms can be used in the public domain in future. So actually, although it's very unfortunate that all this has happened, it's I think it's provoked a welcome scrutiny of these ideas. I should also add that I have a lot of sympathy for the statisticians and others who developed these algorithms. I think they were given a fairly impossible task to square that circle.
Okay, well, it's good that you're loyal to your colleagues. I expect you that. And it's also good that you are on these authorities, actually. It's reassuring. All right, so from mutant algorithms, we move now. We don't normally allow people to show slides. In fact, you're the very first person that we've given this privilege to, because I think it is pretty, even for a fluent talker like you, it is difficult to get over some of the messages that I think you're going to want to convey. So I'm going to hand over to you, and we're going to start, I think, with, we're going to look at the perennial topic of basically deaths from COVID. So over to you, David.
Yes, I'm afraid I'm only going to look at the show pictures about deaths. It is the best quality data available from the Office for National Statistics. And of course I would say that, wouldn't I? And
yes.
I just want to put on, otherwise it's too difficult for me to wave my arms around and try to put over some of the points. And I'm just going to show 3 slides just to illustrate some of the issues that I think are topical and gripping and still of huge relevance as we have passed the peak of the epidemic. Okay, let me see if I can just share my screen now and go over to the first slide. That's up to date from last Tuesday and just shows the excess registered deaths in England and Wales over the 5-year average, right since the beginning of the winter. We actually see after Christmas there was a deficit. It was a mild winter with a mild flu season. So one idea is that that built up a certain number of susceptible elderly frail people who might otherwise have died during the winter. Then we can see this massive spike, unprecedented, unlike any flu season, spike of COVID deaths. We can see the interesting thing perhaps is when we see this gray here, these are the excess deaths were not labeled as COVID. We'll come on to a bit more on that later. And then we see a drop. It's very bumpy because of registrations, bank holidays, changes that. But then from the about middle of June or end of June, we're actually dropping below the average number of deaths. And so, you know, that brings up all the ideas to the extent that some deaths may have been brought forward. Again, the frail people who have died from COVID, who would otherwise be dying now. There's been a recent little peak, which you can see, but it's thought, and Office of National Statistics conclude this is probably due to the heat wave. Okay, so that's the broad picture. There's a huge spike, come down, now we're below average essentially. The next picture I'd like to show is looking at that in more detail, the place of death. I find this is riveting. This is our own software, our own images we're producing from our software. You can go onto our webpage and look at these images, which are updated every week. And what this shows is where people have been dying during this epidemic. And we can see this massive spike, of course, in deaths in hospital. But what we also see is that the non-COVID deaths in hospital not only dropped enormously as people were not going to hospital, it hasn't even come up to normal. In care homes, a huge spike in COVID deaths, big spike in deaths that are not labeled as COVID, now pretty well back to normal. But this is something, the area that I think has not received the attention it deserves, what's been happening in individual families' homes. There's no organizations to support them. There's actually only a couple of thousand deaths from COVID that have been registered in people's homes. Huge number of non-COVID deaths happening in people's homes. And that pattern there almost exactly matches the drop in non-COVID deaths happening in hospital. And it hasn't changed, it's still going on. 800 deaths a week that would normally happen in hospitals are happening at home. People are not going to hospital. Now, that may, people would prefer to die at home, and if those deaths have been properly cared for, with proper care of the family and the person who's dying, then that's fine, that's fine. However, are they? We don't know. And also how many of these people might have lived longer had they gone to hospital. So this issue of people not attending hospital, which we know will affect downstream cancer cases and things like that, is still going on and is, I think, not getting the attention it deserves. The other thing I think is terribly important is that, there's absolutely right that there's a lot of discussion about the roles of ethnicity and occupation and deprivation in terms largely of catching the virus, but also what happens if you catch it. These are absolutely crucial issues. However, what can get lost is the massive importance of age. And people do mention it, and Chris Whitty's been rather good, always saying that this is a disease that can be very harmful for the elderly, not very harmful for the young. And the picture on the left here just shows on a logarithmic scale what the death rates have been for 50,000 deaths or so for the different age groups between essentially 0 and 95. And that's on a log scale. Now, that is a straight line on the log scale. So the dots are the COVID deaths, the dashes are normal deaths that happen. That's the normal deaths that happen regularly. That is, I've never seen anything like that with such a straight line. That's not smooth, that's the raw data. And it shows, almost exactly exponential increase of risk of catching and dying from COVID that goes from age 2, essentially, right up to 95. The 12 to 13% higher for each year older. This is a horrible form of compound interest, which means that your risk of dying doubles every 5 to 6 years. There's more than a 10,000-fold variation in risk between the elderly and the young. And this is, I think, an extraordinarily powerful idea, which if people would really grasp this, would explain quite a lot, I think. If you look at the current infections are being reported in this country by Public Health England, the group with the highest infection rate at the moment are the 15 to 44-year-olds. And they've got a very low death rate. I think 30 in that middle, if you 5,000 30-year-olds caught COVID, you'd expect maybe 1 or 2 deaths. So I think that can explain to a large extent why we're not seeing so many hospitalizations and deaths following the recent outbreaks. Okay, I will now shut up and try to answer questions. But those are some of the things that have been, in a way, exercising me and as a statistician looking at this data that's coming in every week.
That was, and by the way, your slides are very impressive, I must say. I'm almost converted to go back to PowerPoint, but not quite. I mean, questions have been flooding in. My old friend David Colquhoun, the professor of pharmacology at UCL, I'm sure you do. I think he just wants you to elaborate a little bit on what you've just said now, which is basically, how long would we be waiting before we might see an increase in deaths in old people infected by the young people who are now currently the main people getting the epidemic? And we're thinking about the US, where it did take some time before the increase which started in the young, unlike in the UK, was transmitted to the elderly.
Depends completely on people's behavior and their mixing. If the virus is currently being passed among people who are younger people who are mixing in closed environments where they're talking loudly at each other, whatever, then then that's not going to spread to older people, except if they live in multi-generational households and so on. And so I think it's very difficult to know, because it depends so much on the patterns of behavior among the groups in whom outbreaks are happening at the moment. So I wouldn't like to say, I haven't looked in detail. I know in America for a long time this was happening, and no increasing hospitalizations and deaths, and then they have started coming up. So I'm not going to predict what's going to happen in England and in this country. I just find it actually, because reassuring that there haven't been signs of that happening yet, and we need to look at that carefully. We obviously keep very careful look at that.
I also think we should remember that most young people are not feckless, massive risk takers, and even if they themselves may be interacting, and I can understand why they would be interacting with each other, that does not necessarily mean that they would be reckless in other situations.
There's something I must say as well. I've only looked at deaths because that's the easy data available. I must always emphasize that there are many people, in younger people as well, who, having survived COVID, are having long-term effects of the disease of this virus. And so that is obviously a very important area in which the data is rather weak at the moment, but clearly needs to be strengthened. Okay,
I'm always sorry I did ask you about algorithms, because now everyone's piling in with all sorts of things on algorithms. We're going to go back to COVID, I'm afraid. I shouldn't have done that.
Yeah.
So next thing is, I do want to talk a little bit about comparisons, because I think it's much ado about nothing, isn't it, where they say comparisons are odorous, which is showing that even Shakespeare knew about a pun and a sense of humor. But they're inevitably what we do. And the first thing is, could you just talk a little bit more about this issue? We're comparing national boundaries, but how ridiculous that is in understanding the transmission of COVID. If we look at the macro, the artificial boundaries that we have in Europe, the result of war treaties, etc., how can this hide some of the variations that's going on and some of the knowledge that we would miss if we simply looked at France, Spain, Britain?
I think we should be making comparisons because there are natural experiments going on with the different ways in which different countries and different regions have been handling the virus. But I suppose, as what we'd all say is that just be cautious about it. I've seen some studies where people just shove 50 countries into a regression equation and put in a whole lot of variables about their attitudes to face masks and drew some conclusions about the effect of face masks. This is completely nonsensical. I mean, countries do vary so much in terms of their behaviors, in terms of their population densities, in terms of their mixing, the amount of travel that goes outside. We think of all the huge proportion of Sweden that takes winter holidays, in Spain and France, that brought the virus back to the whole country, just as happened in the UK as well. So there's so many subtle issues that need to be looked at. But of course, we should be making comparisons continually as we go along, in particular where countries, other countries have opened schools earlier and have not shown, apparently, a great burst of transmission arising from schools opening. That's incredibly valuable information in terms of the fact that people are doing things differently in a rather uncontrolled way. But if we think of it as a natural experiment, this is data we must be learning from all the time.
I think that's fair enough. But then, as far as I understand it, this is really reading from some of your stuff actually, but that the highest rates were in particular areas like northern Italy and central Spain. But the reason that the UK looks worse or bad in deaths, even though we've reclassified, is that unlike them, we were not able to localize our epidemic to some very high areas, which happened in Italy and Spain.
I found it one of the most chilling animations I've seen came out of the Office for National Statistics, which was comparing countries, which was a time series looking at outbreaks around Europe. And you could see this really tightly focused outbreaks in North Italy, particular areas of Spain going on. And then suddenly it erupts all over the UK almost simultaneously. Obviously more in London to start with, but and not so much in the Southwest and other countries, but there, boom, the whole country, really was hit simultaneously, as apparently everyone came back from half-term holidays, having gone to Spain and Italy, especially northern Italy. So, in a sense, we're unlucky.
Yes.
I mean, I'm not saying that, oh, therefore, that explains everything that happened to us. I don't think I'm alone in saying that, if I try not to criticize what people have done, but I think the lack of testing ability in this country meant that we were operating in the dark for a long time. We just didn't know what was happening and just how much there was around. I mean, really quite terrifying when you think of how it was spreading at that time at the end of February, beginning of March.
Okay, still on the subject of death though, Ian Harvey is asking, how long will it be before you feel that we do have the full picture of how the UK or its component parts did compared to other countries? Because you've said that in statistical terms, it is still early days and there are various equilibrations that could happen. But when do you think you'll be in a position to actually deliver a firm statistical verdict?
I mean, the latest, if you look at, the first thing is to be very skeptical about deaths that are labelled as COVID, even in this country, especially early on. Look at those care home deaths I was showing you early on. Huge number of deaths in care homes not being labelled as COVID, which I think probably were largely under diagnosis. So if we look at excess deaths, just the area above that, the average, England's the worst in Europe, and age adjusted probably per million and so on. So we can conclude we've done very badly. I'm not going to give a reason, a fast reason, but we have done very badly. We know that. What will happen in the longer term is also, a big issue where it's going to be very interesting seeing Sweden had a more relaxed attitude, although even they don't seem to have had, you might think that they might have therefore had a larger number of younger people catching the disease, which would help towards herd immunity. Doesn't seem to be that large. So we'll be interested in seeing what happens then, relating the longer term effects to what's happened earlier on. But it's going to be so complicated because of the downstream effects of lockdown, of the almost not the closure, but the protection of the NHS has meant that so many people haven't been going to hospital, been such disruption to routine care. What that'll mean, I think it's really good. People have been making predictions about downstream cancer deaths and increased mortality and so on. Difficult to say. I mean, in a way, we've got a natural experiment about whether hospitals actually do much good or not.
We've got a lot of natural experiments. Carol Sikora has been saying that more people will end up dying of cancer than will of COVID. But Carol Lee of London Brand Innovations, I'm not sure what that means actually. But anyway, she's actually specifically picked up on Sweden, and I have this obsession with Sweden, which I tease Martin McKee on whenever he's around. But she's asking, had we followed the Swedish model and had a more minimal approach, is there any way you could, do a bit of a mystic Meg and wonder what the outcome might have been over here?
I wouldn't want to do that. What I would want to say is that it wouldn't have been better, and we did worse in Europe. So, if we had had a more relaxed approach, I don't think anyone would claim that the impact would have been less. And it was bad enough as it was. And so that's all I can say. I'm not going to try to say how much worse or what what was right for Sweden necessarily. But again, Sweden, it didn't protect its care homes, which they fully acknowledged that a regime that might have been quite reasonable for the bulk of the population, they didn't protect their vulnerable.
And some things are just mysterious, aren't they, David? I mean, the only country left now that we can visit reasonably is where you had your last holiday, in Coimbra, in Portugal. Portugal and Spain are the same landmass, quite similar culturally. Food's not quite so similar. But how come Portugal is still a place we can visit and seems to have done better than its neighbour Spain? I mean, these are kind of, some things are just weird, aren't they?
I'm not an epidemiologist. I'm certainly not an expert on the transfer of the spread of a virus through a population. But it's quite clear that especially when you look at within Italy and Spain, that this is strongly focused in the way, as you would expect an epidemic to be, that it gets focused in particular areas. And so it's quite reasonable that areas that are some distance apart, where there's some natural barriers, as there are between Portugal and Spain, it's not, you don't move between them very easily at all. And so I think that there's completely plausible. I mean, if Rome can be so different from Milan, it's not so absurd that Portugal can be different from Spain.
Okay, now let's move slightly here. Then again, a reasonable question is Peter Allen, who's chair of health and wellbeing for London Borough of Richmond. And now he's looking at now you are the professor of risk as well as statistics. The two are not the same, but they're very similar. But he's asking about I think that some of our Scottish colleagues, and indeed Nicola Sturgeon, is clearly talking about a COVID-19 eradication or zero COVID strategy. He's saying, is the concept of acceptable risk comparable or compatible with the idea of total eradication or zero COVID? So I think we're getting into a discussion of risk here.
Yeah.
How much risk can we take?
I think this is just the right direction to go in. This is turning from a societal threat into a risk management issue that's not going to go away in any rapidity at all. The discussion, even a vaccine, when it eventually comes, if it eventually comes, is I think unlikely to be like smallpox or something where it just sort of protects you from forever. So we are faced with a risk management problem at a societal level and at an individual level. We're all going to have to make these decisions about whether we want to stay shut in or whether we want to go out and take a certain amount of risk. And I think the idea of acceptable risk is deeply important, and it comes from health and safety. Health and safety have got a fantastic structure called the Tolerability of Risk Framework, TOR, which has been unbelievably effective in health and safety culture in this country, in which they don't say whether something's safe or not. There's nothing safe. Everything is either an acceptable risk, below an acceptable risk, in which case it's tolerable, above an unacceptable risk, in which case this is completely unacceptable, and in this situation you might want to just lock down again. And in between there's this area where the aim is to make the risk as low as reasonably practicable, where you are bringing in measures to try to bring the risk down to an acceptable level. And I don't actually, if you look at the zero COVID community in this country, they're not talking about total elimination. They are talking about acceptable risk, at having such intensive surveillance and testing and local measures that it's brought down to essentially an acceptable level of infections. They're not talking about complete elimination. I think that's completely reasonable. And actually, if you look at, one can think of two sides of this debate. You've got the zero COVID side, which is, portrayed as being, very anxious and trying to, get rid of it completely. And then at the other extreme, you've got the more libertarian side saying, oh, well, all this lockdown was unnecessary and it's going to go away on its own and this sort of thing. I get quoted by both sides, as I sit in the middle, getting quoted and abused by both sides, which is great. So I must be doing just the right thing. And I don't think they're quite so far apart, because actually what they are saying, both of them, is that this needs managing. We need to bring in measures that are appropriate in order to bring the risk down to a tolerable level, at which case we can start opening up. But we will never be safe. We are never going to reduce, it's not going to be like smallpox, I don't think, as far as I know. What I read, it's not my area, but that's what I understand. This is going to be one more risk, like road accidents, like terrorism, that is just going to be there, and we're just going to have to learn to live with it to some extent. And we will change our behaviors, and we'll change things, and we're going to have to get used to that.
And it's ALRP as low as reasonably possible.
I think that framework, which I use when I'm talking about alcohol consumption or any behaviours, we should never talk about that safe. Nothing's safe. Going to school isn't safe for kids, and so we just need to talk about trying to bring the risk down to an acceptable level.
Although I should also quote from your book to say there's never been a better time health-wise than to be a school kid than at this moment in time. Yeah. And we shouldn't lose sight of that. Ashok Roy then has come up with what actually leads very nicely from what you're just saying, which is in terms of the as low as reasonably practical, but this is people usually do over time get used to situations, sometimes really remarkably quickly. They habituate in psychiatric terms. How can statistics, though, be used to help that process of habituation and getting used to the idea that, look, it's going to stay, it'll never be completely safe?
Yeah, it's difficult because, we can quote average risks all the time, But as I showed when I looked at age, average risk is almost pointless because they vary so enormously from person to person. It's just like average R, average anything else. When we have something that's so localized and so variable across the country, across different regions, across the towns, across different houses, then in terms of the risk, that it is very difficult to get to quantify what an individual's risk is. They always ask. I mean, I'm working with others on individualized risk indices, which would give a risk of catching and dying from COVID, and these hopefully will be made public. There's already a number available where you can put your details in. It'll tell you various risks and so on, and that's very useful. But it can only tell you, things in a broad picture. It's better than just an average. It's better than just talking about your age and sex, or whatever. It can be more detailed. But of course, the risk of dying or being ill seriously if you catch it is fairly fixed. It's a function of your characteristics, your vulnerability. The risk of catching it is so variable. I mean, I can change the risk of catching it just by my behavior and where I live and what I do. And so that is something, the analogy that I've stolen from somebody else is the idea of a pollen count. A pollen count.
Oh, pollen, yes.
Yeah, so individuals can be told about what their vulnerability is, their sensitivity to pollen. But the pollen count is going to be varying all the time, and we would change our behavior in response to it. And that, I think, is what's going to be happening in the future as we get more and more precise information about, it's getting better all the time, about information about infections in your area and things like that, that people will be aware of, what's happening in their region, and they'll become also more aware of, what are higher risk situations. I find the underground quite interesting, quite clear. With the surveys we've done, traveling on the London Underground is almost the thing that people are most anxious about. And I must say, when I've been on the Underground, it doesn't feel too bad because it's not too full. The idea of a Northern Line rush hour where you're jammed in next to each other and you're underneath someone's armpit, I can't see when that is going to almost ever happen again. I can't see that happening.
As the Northern Line runs under my house, that's not good news.
Yeah.
Okay, now Christina Bundy, I think she's one of our regulars, I think. But anyway, so thanks very much. And also says, please don't stop immediately at once. So we'll go on slightly longer. But she just wants a quick clarification from you. Those slides you were showing, was that for the whole of the UK?
No. England and Wales.
It was
it's Office for National Statistics data, England and Wales, but similar graphs are being produced for Scotland as well. Okay. So it's just England and Wales data.
Now, I want to now ask a question that I'm an epidemiologist by training, and I was frustrated by, now we have ONS is doing their stuff in population-based data, and incredibly welcome that is, both in mental health and all sorts of aspects of the coronavirus. So, and I know you have a conflict of interest because you are on the board of that. That just shows how clever ONS are. But why did it take so long though, David? That was so clearly...
It was before I was on the board, so I don't know the full details, but Ian Diamond, the national statistician, was on the Andrew Marr show just before I was in the middle of May, and he was asked this question, and he replied that they were asked to start doing random population surveys. Oh, I can't remember the date, April the 15th. I don't know the date exactly, but that's when they were formally asked to start doing this. And they got it up incredibly quickly. Of course, I would say that, wouldn't I? But they have done a fantastic job in utilizing, panels of families that already existed, that have volunteered to take part in further research. And you could just go out and test 20,000 families, just go out. I mean, obviously this was a huge amount of work to set it up, but they set it up incredibly quickly and got it working. And now it's being, expanded into a really big, population-based survey of people who have the virus and people who are carrying antibodies. And so, again, I don't want to go over, who should have done what when, but that I think, now what can I say? It was very good that it was decided on that they should do a population-based survey, and possibly it could have happened earlier.
Okay, and what would you say is the biggest at the moment, would you say, the kind of biggest nuggets of gold that finally this is churning up?
Oh, I think again, it's 20,000 families or whatever, but that's small.
Not very many,
what you really need. So I mean, you are finding the current number of people, an estimate, very uncertain because it's still based on fairly low numbers of the number of extra cases per week, the proportion who've got antibodies. Of course, that's quite complex because it doesn't necessarily match the people who've had the disease, because the claims about declining antibody rates and so on. So I think it's incredibly important information to get that, and the more that builds up, the more we'll have a picture of what's going on. But it's still only a broad average picture. Obviously, it can be broken down into regions to some extent, but I think the fantastic nuggets that are coming out are the data, the very localized data, the areas on the PHE and the watch list, the data coming out, extraordinary data coming out from PHE and the Joint Biosecurity Centre on the both the testing rates, the positivity rates, and the number of positive cases in the watch list communities. This is, and the weekly PHE surveillance data that comes out very quickly. These are really great stuff that's coming out there, and will only get better, and people will only scrutinise this more, because the deaths now are not, which is what I spent my time looking at during the peak of the epidemic, is no longer the major indicator. Thank goodness.
Yes, indeed. Now, bang on cue, Martin McGee, who I just mentioned, a great friend of the RSM, has actually texted, said, I'm listening, Simon. Terror into all of us. Yeah. But what he said that we've been a little bit selective in our lesson learning. He says we can learn from other countries that opened schools and didn't have outbreaks. But he's pointing out that there are other places, he mentions USA and Israel, that did. And isn't the issue of the safety of doing that dependent very much on the level circulating the population? And he's now repeating what you've just said, which varies across the UK. So perhaps we should be more selective in our policy, or more regional.
I think, I don't want to talk about schools particularly, but I think just as we're seeing already, that we're going to have to get used to the fact that measures are going to be coming and going in different areas. And, we've already seen that happening, and with different lockdown measures being implemented in different communities. And this is what's going to happen, because actually a nationwide lockdown, I have some sympathy with the critics of that, because it's a staggeringly blunt instrument in which people in which areas in which there's very little circulating virus are having to endure an enormous sacrifice. And so I think it's widely acknowledged that what's going to happen in the future will be far more localized, and that's completely correct.
Okay. Now, Ana Catarina Pinho, who I think must be Portuguese, has taken me to task for even suggesting that Portugal and Spain might be similar. So I
exactly. Yeah, I know. Yeah,
there's a visited both. I'm ashamed of myself.
Yeah.
But now Sir Walter Bodham has also joined in, and this, I think this is an interesting question in terms of years of life lost. He said, in this respect, even the reduction in smoking might have saved more lives than that due to the virus. So is it not better to think of years of life lost rather than deaths? And I think he's saying that we would still have saved more lives with greater attention to smoking during the epidemic.
Well, I wouldn't want to try to do those calculations, but yeah. No, people have looked at years of life, and it is obviously incredibly important. But, actually, fortunately, of course, actually, there's been a very low mortality rate among younger people who have been using a lot of years lost. And the average age which a woman has died has been 84, a man's 81. But these are not people, not all of them, who were at death's door. Each of those, the life expectancy for an 84-year-old woman, I think, is 9 years, on average. And so the people, even these elderly deaths, obviously there have been frail elderly people who have died, and which that definitely could be explaining at least some, maybe all of the current dip below average mortality that we're experiencing at the moment. This idea of mortality displacement, bringing deaths forward, this awful term harvesting that's used. And so I think we are seeing some of that, but it's not, it's not going to explain this huge spike at all. People have made various estimates between, say, 5% to 15% maybe are deaths that would have happened in the reasonably near future. But that's not the case for the great majority.
Okay, the point well made. Now, I've had a flurry of questions also on ethnicity. I'm afraid I can only pick a couple at random, but one here, John Jewell, says, thanks again, David, but any thoughts on improving death registration data? Ethnicity, for example, not being recorded.
Oh, yeah. I mean, maybe I should have a responsibility for that, but that's it's been an absolutely clear lack. And it's not only a lack in the fact that, we don't have the ethnicity data on the death registration, but it's meant that actually we haven't got good data on what is the normal excess mortality for ethnic minorities and things. So to know how much COVID, because if you catch COVID, the death rates seem to, really quite closely match annual mortality anyway. They actually follow it fairly closely. I right back in March, I said, as a rule of thumb, if you catch COVID, it's like cramming an extra whole year's worth of risk into a few weeks. And I haven't shifted one bit from that. It's still pretty similar to that. But the ethnicity, of course, as we're seeing actually in the current outbreaks, is hugely associated also with the risk of catching it. The jobs, the communities, deprivation, the multi-generational households, and so on, greatly increase the risk of actually catching it in the first place. And so, and actually it's quite difficult to split out. We know ethnicity increases the risk of catching it and dying. How much of that is the risk of catching and how much of the risk of dying if you catch it is still difficult to completely split out, because we don't know we've got no database of who actually had the disease.
Okay, so that's clearly an action for you now on the board of ONS. I think you are in a position now to make changes there, and I suspect that will be happening. So one last question from the audience before we finish, but it's Grace Alderson, chair at Bradford, and your title is you're Professor of Risk Communication, and she says, what would you have thought the government should have done differently in communicating, specifically about communicating data and risk to the public? So it's a bit like Ashot's question, but it's more specific.
Yeah. Oh, no, that's difficult. Oh, you really, I could go on for hours about this. And,
don't do that, but a couple of minutes.
I've been known to have a rant on the Andrew Marr show, which went viral, about the daily briefings, which I thought got pretty poor in terms of their communication statistics. A lot of big numbers being thrown around, some not very good graphs and so on. And I went on, and I still would repeat that I do feel that it's the statisticians, the people who know about this data, who should be reporting the data. I think, of course, I would say this, wouldn't I? I think ONS has done rather a good job, and they've been on the radio, they've been on the media, the national statistician been popping up all over the place. So I think they have done their very best to communicate the ideas of what's going on, and a lot of it has got through, like kids being at incredibly low risk and so on. I still think that this overwhelming effect of age still does not seem dependent. People know that older people are more at risk, but I don't think it's very difficult to get this feeling of an exponential difference. We know at the beginning of the epidemic, people found it very difficult, including me, to get this idea of an exponentially increasing number of infections, doubling every 3 days or whatever. And similarly, an exponentially increasing risk where, compared with a 20-year-old, a 40-year-old has got 10 times the risk, a 60-year-old has got 100 times the risk, a 80-year-old has got 1,000 times the risk, is really difficult to get your mind around just how steep that curve is. And I think the statisticians have not done very well in getting that over, because it's really difficult.
Okay, I mean, and let's end on that subject then. We always like to hear about bad stats and bad media, and I would also like to remind the audience of you yourself have fallen slightly victim to that when you were reported as saying that Game of Thrones would mean the end of sex as we know it.
Yeah, wasn't quite what I said. No,
I know, but it added to the gaiety of the nation. But would you like to give us what's your kind of all-time or your current favorite bad stats or bad media in terms of the pandemic, always to leave us on a bit of a high, as it were?
Oh, well, I've got to do this. The the guy, the commissioner of the FDA, Steve Hahn, last week, standing next to President Trump. And, you know, this treatment, convalescent plasma, in a very, you know, not a very good study at all, showed, you know, a 35% relative difference in mortality from, I don't know, 11.9% to 8.9% or something like that. And he got up and said that means out of 100 people being treated, we'd save 35 more lives. In other words, 35% absolute reduction in risk in percentage points. Now, no medical treatment has ever had that effect, I don't think. It would be, you know, the discovery of the century. And yet he got up and said that. It's so clearly, hopelessly wrong. President Trump nodding away. You know, I think it's the, you know, this most statistically dim-witted, you know, utterance I've heard in this whole crisis. And he's up against some pretty stiff competition, I must say.
And President Trump didn't point that out.
No.
Oh, well, what a shame. I was hoping that he might have done. Okay, right, now we have now come to our end. So just don't go away though, David. But and I have to say, I'm quite proud of myself that I have resisted all temptation to link up winter wipeout with what John Bell was saying last year about the winter coming towards us. But the story of you on winter wipeout is available on YouTube, I believe. Spoiler alert, you didn't win.
No.
Okay, now then, next week, another cracker. It's back to school time, or we think it might be, but we'll be having Russell Viner, Chair of the Royal College of Paediatrics and Child Health, together with Amanda Spielman, the boss of Ofsted. So a pretty good cast. And actually, this time we actually have a proper professional in the chair, Victoria McDonald from Channel 4. So that's definitely going to be, again, well worth watching. And our more longer conversation that we do on Wednesdays will be back next week. I'll be talking to Shami Chakrabarti, Common Consent, one of our best campaigners of the generation, but now seen in a less than positive light by some of her previous fans. Let's find out why.
Can I make one?
Sorry, yes, David.
Can I make one final comment? Okay,
yes,
I'm going to backtrack on one thing I said. I did, in a rather rashly, say that I think I might have said we're never going to be in the Northern Line crammed up like this with your head under someone's armpit. It's quite possible that at some point in the future we will be, but I'd like to just change that to saying it's going to be some time before we do that.
Okay. I mean, I think we could, there'll be nothing wrong if we don't come back to that, because it's horrible.
It's horrible.
Yeah, as someone who commutes on the Northern Line.
It's going to be some time before we do that.
But it may not be because of COVID risks. And there'll be things that we didn't like doing that we might get away from, and that would be a good thing.
Well, like going to work.
Oh God, there were lots of questions on going to work. We have to stop. Ladies and gentlemen, first of all, can I just say The Art of Statistics by David Spiegelhalter is available from every good bookshop, not just Amazon. Do please do support your local bookstores as well, where this is available. It's a fantastic read, and it's also quite funny, actually, which you do have a very dry, mordant wit, including your book on sex, which is actually very funny, as well as very illuminating. David, you absolutely lived up to top billing. Fantastic to have you. The questions are just pouring in. We're going to go back to some of them in our roundup, and I'm sure we're going to want you back. That was just brilliant. Ladies and gentlemen, our thanks to Sir David Spiegelhalter, and our thanks to you for watching, and we'll see you again. Okay, good afternoon, everybody.
Thanks very much.
Thank you.